Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 31 of the Strokecast. Meet physical therapist Dr. Brandon Smith. If you want to see more of the content that I share, check out facebook.com/strokecast. I post videos there through Facebook Live about different things that come to mind, and usually they're a little bit less formal than some of the podcasts I do. I actually just recently did one highlighting the different AFOs that I've had over the past year. So head on over there to like the page and check out the videos. Also, if your organization, event, or company is hiring speakers to talk about stroke, recovery, achieving goals, or public speaking in general, I am available. So let's talk. You can reach out to me at bill@strokecast.com. Brandon Smith is a physical therapist who got into this field to work with high-performance athletes. He got his dream, but then he discovered he didn't really like it. I think many of us have been in that situation at some point. Fortunately, he began working with stroke and neuro patients and found us to be much more rewarding. And really, who wouldn't? We are just so much more fun, aren't we? Brandon also brings techniques from sports medicine rehab to stroke rehab, giving us the best of both worlds. After graduating from physical therapy school, he also realized he wanted to talk more about the field with folks who aren't actually in the field. So he started the Physical Therapy Unleashed podcast with classmate and colleague Yong Kim. You can find the Physical Therapy Unleashed podcast in all the expected places, or just go to strokecast.com/Brandon. Brandon has also started his own consulting service, and you can find that link over at strokecast.com/Brandon as well. Now, let's meet Dr. Brandon Smith. Brandon, thank you so much for joining us on Strokecast this week.
You're welcome.
You know, it's always awesome to talk to a PT when it's not one who's wrapping a gait belt around my waist at the moment.
Yeah, but I mean, it's they're licensed, so they have to.
Yeah, exactly. Yeah, I kid, but I've had some excellent PTs in my recovery process. And the whole PT field and the neuro field especially is really fascinating. Well, obviously I find it fascinating having had to go through it from my perspective. But why did you choose to get into this field?
I actually went into it for basically when I went into physical therapy school, I thought I was going to do something totally different than what I'm actually doing right now. But it kind of actually relates to my life. Like I know when I was younger and like in high school, I think my dad had a stroke and I really didn't understand the recovery, but I never actually thought I'd be like a PT helping people with strokes. Eventually, I just started kind of dabbling in things. I kind of found PT. I actually went into PT school thinking I was going to work with high-level athletes. And then through PT school, I worked with high-level athletes, and I hated it. And I never want to do it again.
What was it that you hated about that?
It was basically everyone was entitled. Nobody wanted to listen. And it was basically like dealing with a bunch of spoiled little kids. There are some great ones. I will say there were some actually really great ones. So not all were like that, but the majority that I was dealing with, I was like, this is ridiculous. And then what happened is I ended up doing rotations in neurological units and then just seeing the progress, or with my elderly populations that, they had a stroke earlier in their life and now they have other diagnoses going on, such as diabetes and other stuff that's being managed, like heart failure mixed with the neurological stuff. And it's kind of like, I felt like I was able to make more of a difference by helping the neurological populations. And I felt like it was, I want to say, the patients also appreciated it too. And I kind of like that, the way it works where we are helping each other and becoming friends with my patients along the way. It's not like, hey, I'm seeing you because you have to go get back on the field, like get back on the field really quick. It was more like, I'm here to help you. We're going to get you to the highest level that we can to make you as independent as possible. I know you just had this stroke, but we're here to work with you, educate the patients, educate the families. I really appreciate that side of neurological rehab that I really don't see and many other aspects.
Yeah, I suppose it's got to be a lot more rewarding in helping somebody go from being bedbound to being able to walk up the hall again versus helping somebody get an extra 0.2 seconds on their sprint speed because they're now doing their knee better or something.
What I will say, though, is actually really funny. Everything that I did with professional athletes actually translate to my neurological populations or my geriatric populations, and it actually does wonders for them. So it's kind of, I feel that more therapists actually should be kind of taking some of the athletic training principles into these other populations, because I feel that it hasn't been there before because people are just like afraid. But I've been doing it, and I've had patients go from being wheelchair bound to walking up the stairs in 4 weeks, and it's like I feel like that's a message that needs to get out there. It's just that don't be afraid to, push your patients and see what they can do, because sometimes they will surprise you and progress a lot faster. And sometimes it's okay to take stuff from sports physical therapy and bring it into neurophysical therapy, because I've seen that work.
Oh, that's awesome. What sorts of things from sports physical therapy have had the most interesting impact on neuro recovery?
For me, it's if they can stand and walk, I'll get them up, get them weight bearing. Sometimes I'll take them and put them on. Do you know what an RX pad is? Or I'll explain what an RX pad is.
I don't know. Yeah.
So an RX pad is just a little foam pad, but if you stand on it, it kind of messes with your balance. You have to work a lot harder. But by standing on the foam pad, it causes kind of your whole body and nervous system to really stabilize yourself and contract. And that's good for athletes because it prevents injuries. But in the neurological populations, by putting them on that pad, what it actually does is it kind of almost fires up their nervous system. And I've just put them on that, had them do a few squats and parallel bars or holding onto their assistive device. And all of a sudden, they're able to take higher steps, walk further, be more independent, just because it kind of activates that neurological system.
Interesting in providing that different feedback to the brain and having to go ahead and do the balance. I do remember we're actually working with that in the parallel bars when I was inpatient rehab. But I hadn't realized that was also something that was part of the athletic programs as well.
Yes.
It's like one of the interesting things I did with one of my PTs too, was towards the end of it, it was a nice day. So I was just like, teacher, can we have class outside today? And so we made a part of the PT session then was focusing on walking on the uneven lawn and trying to balance in that dirt, because that posed a very different challenge than I had encountered in the hospital. So it's interesting how that plays into it.
No, it sounds like you had a good PT. That's what I like to do, is push patients like that. And I'm glad that other people are doing it as well.
Yeah. Yeah, that's fantastic. It's one of those things too where, people may have physical limits, but if they decide they cannot do something, and if nobody is willing to dispute that with them, then they're not going to be able to do it.
Yeah, that's one of the biggest barriers I come into in all populations, especially in my older populations, is just that mental barrier. Like, my whole life it's been this way. Why should I change? It's like, okay, well, let me sit down and talk to you.
Sure. It's like, how's that working for you?
Yeah.
So what's been the most exciting aspect then about being in neuro PT?
For me, it's just been the presentations. I've seen. Actually, the other day I had a really interesting presentation, probably the most complex thing I've ever seen. This was actually a little bit further down the line. So I've seen.
And by a presentation, what do you mean?
When I go to do an evaluation, so the PT comes in for the first time, kind of examines what's going on. Mm-hmm. So I've been in the neuro ICU, and then I've also followed strokes later on. This would be one of my later on presentations. And so this patient had a hemorrhagic stroke, which have you covered hemorrhagic strokes before? I'm sure you have.
We have.
Okay.
So basically, hemorrhagic stroke is a bleed in the brain, and when normally there is a barrier between the actual nerve tissue and the blood in the brain, and when blood does great things, it provides oxygen and nutrients to the nerve tissue, and it takes away garbage from the nerve tissues. But when blood actually touches the nerve tissue and gets in between the nerves and the connections between them, very bad things happen to the brain.
Yes. 100%. So this patient had a hemorrhagic stroke, and she had 2 ischemic strokes. And the 2 ischemic strokes, apparently a few years prior, she missed the window for TPA. Yeah. So this patient had a history of 3 strokes of all different kinds. And then she also had a neurological disease of secondary progressive multiple sclerosis.
Ooh.
So multiple sclerosis, just to kind of sum it up, it's basically takes away the lining of the nerve, slows down nerve conduction, degenerates the nerves over time, especially with the secondary progressive. And so even though she had a stroke at one point, the MS is actually changing the presentation. So it was one of the most unique things I've ever seen, where it was like she had sensation loss on one side of her face, but then the opposite arm was sensation loss, could move one arm, could not move the other arm, had no actual voluntary control of her leg, but her reflexes wouldn't stop. So it was one of the weirdest things I've ever seen.
Huh.
Yeah.
That's fascinating.
Yeah. And I was just like, okay, so I'm actually just saw her the other day, so I'm going to see what's going to happen, because it's probably the most complex neurological case I've seen.
Right.
Yeah.
And as you start getting something going, getting some of the neuroplasticity going in one way, with everything coming together, it's like, yeah, I wish her luck. That is complex.
Yes. And then another thing I saw that this was, I don't know, maybe 6 months ago in the neuro ICU. I had a male patient that decided to party too hard, took too much Viagra, and the Viagra caused him to have a really bad stroke.
Interesting. Well, I suppose if Viagra works by messing with the circulatory system to begin with.
Yes, he was not happy.
Yeah.
I can understand why.
Yeah. Yeah.
So those are kind of the 2 most interesting. The other ones were kind of, one hospital I was at was in a very poor area, and there was a lot of strokes from smoking a lot of crack cocaine.
Uh-huh.
Unfortunately, I'm starting to see that a lot in the poor populations. It just seems that people aren't really educated that they can have a stroke if, smoke crack. So
yeah,
it's so don't smoke crack, but
for many reasons.
For many reasons, but it's some of the things, something I've seen actually a lot more commonly in the poorer populations, unfortunately.
Interesting, where folks are then also less likely to seek professional health care if something does go wrong. And yeah. So those are kind of the 3 most interesting things that come to mind as far as neurological. Wow. What's the toughest thing about working in neuro ICU?
I don't really think it's that bad. The hardest thing is probably educating the families, because the families are like, oh my God, what's going to happen? He has to go back to work tomorrow. And it's like, okay, he's not going back to work tomorrow. So,
right.
So for me, I think the patients are actually more understanding. I think it's mostly just educating the families. I think the more education that you can get out there about stroke, about the different types of stroke, about the recovery. Unfortunately, some people don't get to the hospital in time for TPA. Sometimes things just don't get past a certain point in recovery. But the goal of all rehab is to get your loved one, yourself, the patient, to the highest level of independently function they can. So we're going to do our best to get them to be that highest level of function. And I think that's what people need to understand is, some people, I've seen some strokes reverse very, very fast, and the person's fine in 2 days. And I've seen some where someone's been stuck kind of in a pattern for years. But the goal is really just to make everyone as independent as they possibly can.
So in terms of looking at what happens from neuro ICU or neuro acute care, how do they make what determines when someone's ready to move from that into, say, inpatient rehab and really start focusing on that hardcore recovery again?
It usually depends on what's going on, at least in the hospital systems I've been in, with social work, getting benefits. Unfortunately, those with better benefits usually get moved faster. Those with less benefits sometimes don't get placed and get sent home. And that's just an unfortunate reality that happens, because healthcare, I don't think it should happen. It kind of upsets me when it happens. But ideally, anybody that has had a stroke and needs recovery should go to inpatient rehab within a few days. Unfortunately, that doesn't always happen due to benefits, due to social work, due to overbooking, and depending if you're in a big city. I've seen patients that were supposed to go within 2 days, been in the hospital about a week. Usually, though, everyone does everything in their power to get someone placed. And I will say that I've sent almost all my patients, I'm putting this in all my patients to inpatient rehab, which inpatient rehab is 3 hours a day of therapy. And it's not just physical therapy, it's occupational therapy, it's speech therapy. So it could be mixed, but the patient has to be able to tolerate the 3 hours a day of therapy. So sometimes if they can't tolerate the 3 hours a day of therapy, they'll stay in the hospital a little bit longer or go to a skilled nursing facility and then get transferred. But ideally, I try to get everybody to tolerate a lot of therapy early on, because the more aggressive we can be and the faster, the better outcomes we have seen.
That is really becomes really important for, not letting people also settle into patterns of thinking they can't do something.
Yes, yeah, and that's why even neuro ICU. So what happens is when they get the TPA for an ischemic stroke, we have to wait 24 hours to make sure it doesn't turn into a hemorrhagic stroke. And hemorrhagic stroke, we just wait until everything is clear. But usually, as soon as they are cleared, we get them up immediately in the neuro ICU to show them that, okay, like, you've been medically managed. Let's go. We're going to get you back to the highest level we can.
Yeah, that is doing the great work there. One of the other things that's really interesting is just the wide variety in care that's out there too. I know I have been lucky for very many reasons in this process. For one thing, just with my stroke, I broke my basal ganglia and had physical deficits, but really, it's not like I lost any significant athletic ability. I'm probably just as good on the softball team today as I would have been before the stroke. But Seattle is one of the best places in the country to have a stroke and to have to go through the recovery. And it sounds like in your facility, that's the case as well. But one of the other things I've been hearing more and more is that when you start looking in some of the communities in the southeast part of the country, you find that there's just a lot more variability in terms of the quality of care that folks get.
Yeah, it really depends. When I've been in the neuro ICU, I've been at one of the only comprehensive stroke centers in the Miami, Florida area. And when I was in that area, there was anybody with a stroke came there because it was a comprehensive stroke center. Unfortunately, I think there's only 2 in the whole state. That may have changed, but I know about 6 months ago when I was at that facility, there was only 2 in the whole state. And Florida's a rather large state.
Yeah, there's definitely a lot of people there with a demographic that's more prone to stroke too.
So I'm not really sure. I think other hospitals are implementing certain procedures. I believe that the education has to get out there. I think a lot of it comes down to administration too, budgeting. I think there's a whole business side of the medical world that people don't want to acknowledge, but people are starting to acknowledge it now, and hopefully it's starting to change.
So you also have a podcast about physical therapy. Why did you decide to start that?
When I was in PT school with my classmate, we're both now physical therapists, we realized that everyone in PT was marketing to each other and not to the consumer about anything that we do. And we got kind of tired of seeing physical therapists tell other physical therapists how good they were. So we're like, okay, we're gonna create our first episode dealt with our education, and our first episode explains that now we're all doctors of physical therapy. I think now it's required to have a doctorate in physical therapy to pass your licensing exam. All the things we cover, from back pain to stroke to pediatrics to amputees. So our first episode kind of covered our education and what we do. And now what we do is we kind of pick a topic and go just educate the public on what a PT can do to help, or we take in-topic requests and educate how to find the best provider. And even if a PT can't help, our goal is to refer to somebody who can help, no matter who that is. So that's kind of our public-facing podcast called the Physical Therapy Unleashed podcast. Is basically, we just got tired of the public not being educated by our peers, and we're just going to take over. So
that's how a lot of this stuff happens.
Yeah.
That's awesome. So your audience then for the show it's really targeted then at the general public that doesn't have as much knowledge about the medical field.
Yeah, that's really the goal. Sometimes if we say anything that's not understandable, we always ask to email us or Facebook message us, and we clarify immediately. But we try to really break it down to the consumer, patient, client level. And it can be anything from wellness physical therapy, like you hurt your knee squatting, to helping a caregiver or teaching a caregiver how to help their mom not fall as much and stuff, and other situations like that.
I imagine some of your folks in the your colleagues over on the occupational therapy side of things could probably also take that idea and run with it, because there are a few fields that have worse branding than occupational therapy.
Yes, I know. I work a lot with the geriatric patients, and I was told I can't say elderly anymore, but I'm going to say elderly.
Okay. Fair enough.
Just because I've said it my whole life, it's hard for me not to just say that.
Right.
So my aging adults, I guess. My aging adults.
You're more experienced adults.
Yes. I had one of my occupational therapists go try to do an evaluation, which I talked about earlier about, it's kind of when we see you for the first time. And occupational therapy has that same process where they see you for the first time, develop a plan of care. And she goes and she sees one of my patients, and he's like, I don't have an occupation. Why are you here?
Yeah.
So he's like, stop wasting my time. So we had to explain to him that it's not for him to go back to work.
Right. Right.
So, yes.
So what do you wish more survivors, caregivers, or aspiring new medical professionals knew earlier in the process of working with someone with a stroke?
I think that it's really important for no matter who you are. And I know some of this may seem overwhelming, but kind of maybe even just watch a YouTube video on how the nervous system works. I know there's like 3-minute videos out there called like 2-minute neuroscience. And it kind of just explains how everything works. And if you're a provider, I would want you to educate yourself, even going into the field as much as possible, on the nervous system, on the brain, how different parts of the brain, such as basal ganglia, like you mentioned, affect motor control, affect different areas. And that way you can then educate the caregivers, educate the patients, educate the families. Because I feel like once we all understand what's actually happening, care becomes much easier.
Yeah, that makes a lot of sense. And anyone in any field just also gets to the point where you're living and breathing this stuff all the time, so it's just second nature and painfully obvious. But when you start dealing with someone who doesn't come from the field, like a new caregiver, like a new survivor, it's easy to forget that a lot of these very basic things that we may think of as basic are completely alien to them. And they're smart people. They just haven't had reason to educate themselves on it until now.
Yeah, and I always try to break it down as simple as possible. I'm always give them my phone number if they have any questions. I always try to really break everything down. I know it's hard. I know it's complex stuff, and people are like, I don't want to learn any of this. And it's like, okay, well, this is going to help with care. Another thing I do want to mention, though, is I didn't really bring this up earlier, but also if that patient has a goal, even as ridiculous as it is, say the patient wants to play baseball, what I will do in my treatments or have the caregivers do is try to get them to play baseball seated in the wheelchair, because it kind of brings them fun. Like I've tossed baseballs to patients that have had stroke, and they try to swing and hit it, and they love it. So it's kind of like always try to include some patient-centered activity like that. No matter if you're a caregiver, the family, if you know, especially if you're the family or caregiver and you know what they like, try to include it in some way, even if it's modified, because it's kind of almost promotes their mental health as well and helps with recovery.
Oh, that is fantastic. And, that's sort of the whole point of a process is you have to have a goal. Even if it is a big, hairy, audacious goal, you got to have one. Because if you don't have that goal, if you don't have that target in mind, you can't begin to go after it. Yes.
And that's what I always do is I always try to include my patients' goals and everything that we do. I have to have my own goals for Medicare and Medicaid reimbursement purposes.
Right.
but and insurance reimbursement in general. But I always try to include, and this is something I learned as a student actually, is I actually had really good instructors and professors that were always like, make sure you put the patients first and make sure that whatever you're developing, their plan of care, no matter what setting, you're always having their goals in there. And I feel like that's helped me a lot as a clinician get better outcomes.
And that brings us to our hack of the week.
Is just know that there are providers out there that help you. Even if you're feeling down, feeling you can't do anything, there is a team of providers out there to help you.
Awesome. So reach out for the assistance that you need, whether that's going to be about your physical care, whether that's going to be about your nutritional care, whether that's going to be about your mental or spiritual care.
Yes.
Brandon, thank you so much for joining us on Strokecast this week. This has been fantastic.
Thank you so much for having me.
I love having therapists and other medical professionals on the show to share their perspective. You know, as we get thrust into the medical system, it's often the case that we don't have the chance to really learn the broader context of what the other folks who are taking care of us do, because we're so focused just on our own immediate recovery, as you would expect. But what do you think about Brandon's story? Let us know in the comments over at strokecast.com/Brandon. Try sharing this episode with your favorite PT and ask them what they think of Brandon's perspective on the field. Just give them that same link, strokecast.com/Brandon. Strokecast is on Facebook, so pop on over to facebook.com/Strokecast to like the page and check out the videos. Be sure to call on additional medical providers if you have additional needs. And of course, as always, don't get best. Get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you next week.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.